I have no relevant disclosures. We have three main objectives for today. First, we're going to review the common ways that small, medium, and large vessel vasculitis may first present to the PCP. Then we will go over appropriate diagnostic testing for these different types of vasculitis. And then lastly, we'll understand typical treatments for vasculitis and how the PCP can assist in monitoring for both side effects as well as disease evolution. So first, we'll do an overview of the different types of vasculitis that we will discuss today. And I see many of you probably have recognized this picture on your left, seen in medical school, residency, and beyond. And basically, it's an illustration of the different size vessels that can be involved in vasculitis. So we will look at small vessel vasculitis, in particular, Leukocytoclastic vasculitis, also known as LCV. We'll briefly go over ANCA-associated vasculitis as well. And then for the medium vessel vasculitis, we'll look at Polyarteritis Nodosa, because of the two types, this one is more common in adults. And then for large vessel vasculitis, we'll look at giant cell arteritis, also known as GCA, and temporal arteritis, and then Takayasu arteritis. And then we'll look at a few more other kind of vasculitides known as immune complex mediated. In particular, we'll look at IgA vasculitis, cryoglobulinemic vasculitis, and hypocomplementemic urticarial vasculitis. So starting off with common early symptoms for Leukocytoclastic vasculitis. So first, for this disease, it's important to know it's pretty much cutaneous limited. And this rash can be characterized by both palpable purpura as well as petechiae. And just to review, petechiae are fairly small, around 2 millimeters, and purpura are a little bit larger and can even be collections of petechiae all together. And this differs from erythema nodosum, which also can be found in the lower extremities, but is much larger, always raised, and very tender. As you can see in the picture to the right, this is a person who has very extensive LCV of their lower extremities, where it may not always be this pronounced. Sometimes you might only have a handful of lesions. So findings can be quite subtle depending on the situation. But unlike erythema nodosum, these findings can be present both in the lower extremities, thighs, trunk, as well as upper extremities. And so keep an eye on that. Because it's cutaneous limited, for the most part, people typically do not have systemic manifestations such as fevers, chills, cardiopulmonary, ENT, GI, or GU symptoms, or MSK or neurologic involvement. Now, a lot of times the rash can be idiopathic, but there are some common triggers that we see on a regular basis, in particular infections such as strep or hepatitis, various medications, including some antibiotics, phenytoins, as well as diabetes drugs, and then various food allergies. Now, another less common trigger, but definitely important to note, is malignancy. And I've seen this a few times in the last few months. And so it's also very important to keep in mind, especially in patients who have some constitutional symptoms and this rash, that there may be something else going on. Additionally, if a person has this rash and they have other constitutional symptoms, or they have GI symptoms, or it just seems like there's more than just a skin rash going on, it may be IgA vasculitis, and we'll discuss that a bit more later. So how do we work up Leukocytoclastic vasculitis? So we want to get some labs, and because this can be an inflammatory process, we recommend getting inflammatory markers in addition to regular CBC, CMP, and urinary studies. And because infection is a common trigger, working up for ASO titers as well as hepatitis serologies and other infections that may be common in the season that the person is presenting to you could be helpful in determining if that's a potential etiology for this rash. And occasionally this can be associated with underlying rheumatic disease as well. So the typical room labs that you might get, ANA, RF, ANCAs, are reasonable to get also, or you can also defer to us. We're happy to help you interpret it either way. And because of the concern for malignancy, we recommend patients are up to date on their age-appropriate screening, as well as thyroid evaluation, lung cancer screenings, and SPEP, as these may be helpful in identifying what's going on. And then, of course, for people who have extensive skin findings and appear to have a lot going on, it's important to consider dermatology evaluation to make sure we're not missing something else going on altogether. And the immunofluorescence can help us to make sure there's no immune complex mediated that could be also going on. There we go. Okay, so moving on now to the treatment for leukoclastic vasculitis. So since it's cutaneous limited for the most part, and sometimes the cause can be idiopathic, they may resolve on their own without any use of medications. And so for these people who may have an infection or a food-related or medication situation, they can just remove the offending agent and things might get better. However, in those cases where you remove the offending agent and things don't get better, it's important to treat it. And we typically start with prednisone around 40 milligrams, and you guys can work with ourselves or dermatology in terms of tapering this further to get symptom resolution. And for people who are refractory to even prednisone therapy, we consider adding agents such as dapsone, azathioprine, or mycophenolate mofetil. If the known etiology is infection, treating the infection usually helps things resolve. Similarly, if the known etiology is a malignancy, treating the malignancy can be helpful. And in the event that there is a rheumatic disease present, we'll be happy to take the lead on treating that underlying disease, which will likely help the rash. For this, we really appreciate our PCP's assistance with, again, checking for malignancy. In this case, people typically aren't on prednisone that long, so monitoring for steroid toxicities is helpful, but since the courses are much shorter, it may not be as relevant. Now moving on to ANCA-associated vasculitis. So these can happen in a broad range of people, teenagers, 20-year-olds, all the way 70s and 80s. And so I know we more commonly see it in older people, but please keep it on your differential in your young patients as well. As I've seen this actually very recently in some younger patients, and it's been pretty aggressive. Unfortunately, the symptoms can be kind of subacute in presentation and take several weeks to months to kind of develop. They may have non-specific kind of vague symptoms such as fatigue, malaise, weight loss, fevers, but be kind of mindful in patients who have new onset sinusitis, recurrent sinusitis, or epistaxis. In particular, if they have some nasal crusting, new respiratory symptoms such as recurrent pneumonia, shortness of breath, cough, even if the cough is dry, and even kind of isolated voice hoarseness can be something to think about in terms of vasculitis. New onset muscle weakness, along with neuropathy such as foot drop or wrist drop are more advanced symptoms, but they can occur, as well as headaches and oral and nasal ulcers. For the most part, the GI system is not typically involved in ANCA-associated vasculitis. So if you're seeing GI symptoms, maybe think of something else, though milder symptoms can be involved. And unlike the previous small vessel that we discussed, rash is not super common in ANCA-associated vasculitis. It's seen in about 30 to 50% of patients. And if you do see it, it may be palpable purpura with ulcerations or livido reticularis or different kinds of nodules. So how do we evaluate this? As many of you know, once again, we would like to get inflammatory markers, in particular ESR and CRP, along with some basic blood work. The UA is very important in this case because of renal involvement is very common in these disorders. And then once again, our room-specific labs. In terms of imaging, since pulmonary and sinus are the most common areas that are involved, a chest x-ray would be a helpful first start. And if you see some nodules or other irregularities, then consideration for a CT chest would be warranted. And similarly, if someone's having recurrent sinus infections, epistaxis, a CT sinus could also be very helpful. In addition to referring to us for further evaluation, a simultaneous referral to ENT or pulmonary, depending on their other manifestations, can also be very helpful, and expediting of trying to figure out what exactly may be going on. And then particularly if they have significant kidney injury, as well as some of these very vague symptoms, it would be very important to get them into the hospital if possible, if the kidney injury is severe, for a biopsy, as time is nephron, and rapidly progressive glomerulonephritis is something that can be seen and is very worrisome in these diseases. So how do we treat it? So with ANCA-associated vasculitis and pretty much all the ones that are more systemic, we think about whether there's organ-threatening disease and non-organ threatening disease. And when we think about organ-threatening disease, in particular, we're thinking about renal failure, as well as pulmonary involvement, such as diffuse alveolar hemorrhage or severe other severe pulmonary manifestations. And in those cases, we're very aggressive with treatment in terms of IV steroids, as well as rituximab or cyclophosphamide, and then subsequent oral prednisone taper. And more recently, there has been a new medication called avacopan that's been released and FDA approved to help with reducing our steroid burden and helping us taper off of steroids faster. Can be a challenge to get sometimes from insurance, but there are patient assistance programs, and my brief experience with it has been pretty good so far. For EGPA, in particular, if the patient has cardiac involvement, we actually prefer Cytoxan over rituximab, as we have seen better outcomes with this medication. And once again, we will do a oral prednisone taper, but avacopan is not used for this disease. Now, if a patient just has isolated sinusitis, no renal involvement, maybe some arthritis, or just a few kind of milder symptoms, they can actually get away with oral therapies. So if they have GPA or MPA, you can do something like methotrexate, assuming they don't have significant renal disease from other causes. And then if you have EGPA, there's a medication called mepolizumab, and that can be very helpful. In addition to some degree of steroids, but not nearly the same dose that we would use in the organ-threatening manifestations. And so in this case, steroids are typically used for a lot longer of a duration, and so we really do appreciate our assistance from our PCP colleagues in terms of monitoring for those steroid side effects, in terms of high blood pressure, new onset diabetes, cataract development, as well as osteoporosis, especially in the older folks. So if they haven't had a DEXA, definitely get one. And if they haven't had one in a while, it might be helpful to update that so we know where we are in terms of risk manifestations. And then similarly, in terms of disease development, just monitoring for any relapse of what presentation they had before that brought them into the hospital or brought their disease to your attention, whether it be sinus infections, pulmonary. If they have a relapse of those, it's very important to let us know, and so we can get them back into care, whether it be inpatient or increasing their current immunosuppressive regimen. So moving on to the medium vessel vasculitis, we're going to talk about polyarteritis nodosa. And so for this one, GI manifestations are the most common. In particular, people have abdominal pain that is most notable after they eat, but it can be present all the time as well. And these patients tend to have some form of diarrhea, whether it be watery or bloody. Of course, bloody diarrhea is more concerning, and you would want them to be evaluated by GI, potentially in the hospital sooner, as well as weight loss. Other symptoms include new hypertension, renal insufficiency, as well as skin manifestations. So this picture that you see on your left is a picture of libido. And that is something that can be seen often in this disease, as well as purpura and ulcerations. Another thing that can be seen a lot in PAN is neurologic manifestations. In particular, you think about mononeuritis multiplex, once again, either with wrist drop or foot drop, and different sensory abnormalities, along with muscle weakness, more proximal than distal. But one key feature to note about PAN versus ANCA vasculitis, which we just talked about, is it typically spares the lungs. So if you're starting to notice this person has significant respiratory involvement, you may want to reconsider your diagnosis. So how do we work up pain? Once again, we want to get labs, in particular inflammatory markers, CBC, CMP, as well as UA, since there can be kidney involvement. And something that we've noticed over the years is that this disease is commonly associated with hepatitis B and C. So checking for those as a part of your initial workup is very helpful. And then HIV as well. But because PAN does not have a particular autoantibody like the other ANCA vasculitis vasculitides do, then we still check those to make sure we're not missing something or we have an overlap between two things. And because there can be kidney involvement, referral to nephrology will be helpful. And if there is skin involvement, referral to dermatology for a biopsy can be helpful as well to make sure we're not missing something else that's going on. In terms of imaging, since GI manifestations are the most common, getting some imaging of their abdomen can be very helpful, such as a CT scan, as seen here in figure A and B. And it shows some dilated bowel loops. But we also, depending on the scenario, may be interested in getting an angiogram or an MRA, but you guys can defer that to us and we can talk about which instances that may be helpful, especially in cases where you think there may be bowel ischemia, like in the picture in figure D. So how do we treat PAN? Once again, similar, think about whether there's organ-threatening or non-organ threatening manifestations. For PAN, this would be more such as renal disease or mononeuritis multiplex are more common as opposed to respiratory involvement, as we discussed earlier. That's rare for this disease. But if there's evidence of hepatitis B or C, it's very important to treat those things first, because you want to make sure you have good disease control before you would give them anything immunosuppressive. And then we would consider IV steroids and then cyclophosphamide once the hepatitis B or C is treated, if that was there. However, if they didn't have renal involvement, didn't have mononeuritis multiplex, didn't have severe GI involvement with mesenteric ischemia, then you could consider oral steroids and methotrexate or azathioprine for the treatment. But if a person had a relapse, then you would go to cyclophosphamide or rituximab to make sure you get the disease under control. And once again, since these patients will be on steroids for a long time, we appreciate assistance with monitoring for high blood pressure, high glucose, as well as cataracts and osteoporosis. Moving on now to the large vessel vasculitis, giant cell arteritis in particular. As you guys know, this is a disease that's found in people who are older than age 50, and most commonly in their 60s, 70s, and sometimes in the 80s. The common manifestations include headache, scalp tenderness, as well as vision changes. And actually the most common vision change that's diagnostic is diplopia. By the time you get to amaurosis fugax or complete vision loss, the disease has been active for quite some time and they need immediate attention. When you think about jaw claudication, it's not simply just pain with chewing, as you might see with a TMJ injury, but it's more fatigability. So it's not pain necessarily with every bite, it's pain after that third or fourth or fifth bite that is a problem for people who have jaw claudication, whereas TMJ is more all the time. So think about that when you're trying to differentiate between the two. And then there's also often a common association or overlap, I should say, with polymyalgia rheumatica in these patients with GCA. So they may also have some morning stiffness in their shoulders and hips, in addition to malaise and just feeling not feeling unwell. And for people who are older and have just recurrent fevers of unclear etiology, extensive infectious workup has been done, malignancy workup has been done. This is something also to really keep in mind. It could be giant cell arteritis, and they may not have any of the other typical symptoms outside of really just fevers and feeling poorly. So please keep this on your guys' differential. So how do we diagnose GCA? As I'm sure you know, inflammatory markers are very helpful, as well as basic CBC and CMP. And what I really want to stress is that if a patient has any of the vision changes that we discussed, diplopia, amaurosis fugax, or vision loss, they should go to the ED immediately for evaluation. For the temporal artery biopsy, if they have other findings, as well as ophthalmology evaluation. As you guys know, there's a lot of reasons to have vision loss, diabetic retinopathy, hypertensive emergency, but in this population, it's very important that we investigate this sooner than later to have any chance for potential visual recovery. However, if they don't have vision changes and they just have a little bit of headache, maybe some jaw claudication, maybe just feeling unwell, and you check inflammatory markers and elevated, then we can evaluate them to see if they can be treated on an outpatient basis. If they do have the headache, it may be worthwhile to also consider ENT at that time for a temporal artery biopsy. Or there have been more studies showing that ultrasound is also a good modality for evaluating temporal arteritis. And the sensitivity and specificity is not as good as the temporal artery biopsy, but it is improving. And in centers that do it on a routine basis, they have actually gotten pretty good results. I would say my preference still is the temporal artery biopsy. And so that's what I recommend, but just wanted to let you guys know ultrasound is coming in a lot of ways. So thinking about treatment. So visual involvement, as you guys might imagine, is an organ-threatening disease. And so that would involve our ED admission, postal steroids, as well as and then followed by a long kind of course of steroid taper orally to try to really get the inflammation under control. We now have a new medication, tocilizumab, that we can actually add as an outpatient to help taper steroids faster, which is very important in this population who really can't afford to have the long-term exposure to steroids. However, there is the contraindication of a history of diverticulitis or other indications that they might be susceptible to bowel perforation. This medication should not be used. And if they don't have visual involvement, we can start these steroids as an outpatient once we have evidence that they have inflammation as well as temporary biopsy is positive, or if our overall suspicion for GCA is pretty high. And once again, we appreciate PCPs with assistance in monitoring for high blood pressure, high blood glucose, as well as cataract and osteoporosis. So can't talk about GCA and not talk about PMR. So I wanted to briefly go over PMR. As you guys know, the diagnosis involves patients with significant bilateral shoulder as well as hip girdle symptoms, in particular morning stiffness. And the stiffness is actually more significant than the pain. They may have some pain, but the stiffness should outweigh the pain because there are a lot of different mimics that also can cause kind of stiffness or pain in those same areas, in particular, osteoarthritis of the cervical spine and the lumbar spine, as well as diffuse idiopathic skeletal hyperostosis, DISH, and then rotator cuff injuries. I've had a lot of patients who have two processes going on. Not that you can't have PMR and these problems, but it's important to make sure that one is not the overwhelming factor in the symptoms. And once again, checking inflammatory markers are very helpful. But also getting x-rays can be helpful in these cases to see if there's any overwhelming evidence of cervical spine stenosis or lumbar spine stenosis. Treatment for this also involves steroids, but we started a much lower dose at 20 milligrams. And we have a slow taper over the course of a year, year and a half. And what's really important about this is during the monitoring, we hope that you guys, as well as our rheumatology colleagues, will be closely monitoring for GCA symptom development, because that can also happen after PMR diagnosis. And so we want to make sure we're not having any new jaw claudication, new headaches, new vision changes, as that would definitely escalate our treatment and change the amount of steroids they need, as well as their monitoring. And then, as we talked about before, monitoring for steroid side effects is going to be critical given the long duration of symptoms, long duration of steroid use for these patients. So moving on to our second large vessel vasculitis, Takayasu arteritis. Unlike GCA, this is typically found in people who are less than 45 years old. And once again, there's can be a subacute kind of vague presentation, but these people have malaise, weight loss, maybe even some low-grade fevers. But the few things that are really important to note is that they're having high blood pressure without a lot of other risk factors for high blood pressure, or maybe asymmetric kind of limb claudication or limb weakness that you wouldn't necessarily expect for someone who is in this age group. In particular, subclavian steal syndrome can be seen, and that's something where people can have feeling like they're feeling faint, dizziness, even vision changes, headaches. And so if you see that when a person is like raising their arms or doing any light activity, you want to be wary of this. So how do we diagnose it? We think about labs in terms of ESR and CRP. However, in this disease, it may or may not be positive. And so it's not our end all be all decision, but we still like to check that to make sure. What's really important is checking blood pressures in both arms to see if there's any significant asymmetry. Similarly, in the pulses, both carotid as well as peripherally, to see if there's any difference there. In terms of imaging, that can be really helpful to look for inflammation, both from a CTA or MRA perspective, and in terms of which one to order, we can work together in terms of deciding on that. Once again, for treatment, prednisone is the standard of care. And we start with methotrexate or azathioprine for our steroid-sparing agent. But if they have very severe disease, then we'll add a TNF agent. And if they have evidence of critical stenosis at presentation in their carotid or vertebral arteries, then we'll add antiplatelet therapy from the onset. Because these people tend to have fairly refractory or persistent disease in their young age, monitoring for steroid toxicity is actually very important because they tend to be on steroids for a very long time. Unfortunately, we don't have same kind of treatments we have in other diseases to get these people off of steroids very soon. So please keep in mind. And lastly, we're going to talk about the immune complex mediated types of vasculitis. And these are probably not seen as commonly, but I thought they were still worthwhile to mention. In particular, IgA vasculitis, as we talked about before, it can look like leukoclastic vasculitis in terms of its rash initially, but these people will have other symptoms, in particular GI manifestations with abdominal pain or other GI issues such as pancreatitis or bowel ischemia. And they may also have some arthralgias, not necessarily frank arthritis, but arthralgias as well as renal insufficiency. And so those are things you want to look out for. This first picture can be a better description of what the rash may look like for IgA vasculitis compared to LCV. And as you notice, they're a bit bigger lesions and they might actually have some bullae as opposed to just palpable purpura and petechiae. Cryoglobulinemic vasculitis is another common immune complex mediated type. And again, it also has a leukoplastic vasculitis rash and kind of distribution. But unfortunately, these rashes tend to have a little bit more ulceration to it, as you can see in the picture to the right. And these people tend to have other systemic features, fevers, chills, but they also may have some cardiac involvement in terms of chest pain, trouble breathing. And so you want to be more mindful of these patients in terms of what else can be involved, even if you're just seeing a rash on the outset. And there is some involvement or some association with malignancy with cryoglobulinemic vasculitis. So you do want to keep in mind if the patient's up to date on their age-appropriate screenings. And then lastly, hypocomplementemic urticarial vasculitis is another fairly common immune complex mediated vasculitis. And this presents with a rash that looks like hives, but unlike typical hives where the lesions will be there and they'll go away within 24 hours, these hives-like rashes stay for greater than 24 hours. And typically after they resolve, there is some type of scarring behind. Whereas a lot of other kind of allergic hives rashes, once they disappear, there's no evidence of that they were even there. So how do you diagnose these types of vasculitis? Once again, you want to think about inflammatory markers and basic blood work. Also urinary analysis because the kidneys can be involved. There is an association with infection for IgA as well as some of the cryoglobulinemic vasculitis, but so we want to check those too. Though there is also the potential for association of underlying rheumatic disease, in particular with the hypocomplementemic vasculitis. There's a great deal of association with those with lupus and Sjogren's, and so we would check for labs looking at those particular diseases as well. And given the concern for malignancy, we once again want to make sure that there's age-appropriate cancer screening, as well as thyroid evaluation, lung cancer screening, and SPEP. Referral to dermatology can be very critical in this particular manifestation, given the fact there is immune complex deposition. They can really help us differentiate what's going on. And lastly, for treatment, for IgA vasculitis, this can be cutaneous limited, and in those cases, we would start with prednisone, roughly around 40 milligrams, and taper slowly. For people who have refractory skin disease to the prednisone, we would add something like colchicine or dapsone, IVIG, or mycophenolate. But if it's very severe, we could consider even rituximab or cyclophosphamide. However, if there's kidney involvement from the outset, we would go straight to the IV steroids and rituximab for IgA vasculitis treatment. For cryoglobulinemic vasculitis, as I mentioned before, there can be some association with infection or malignancy or even rheumatic disease. And so if that's present, you want to treat those diseases first. And for milder disease, you can start with around 40 milligrams of prednisone. And then for the more severe manifestations, start at 1 mg per kg. Depending on the severity, you can add dapsone or rituximab. For hypocomplementemic urticaria, treating the underlying rheumatic cause, if it's lupus or Sjogren's, is very helpful. as well as if it's due to an allergy, treating with antihistamines can be very important, and particularly referral to allergy immunology might also be helpful. And then for moderate disease, I would start with prednisone around 40 milligrams, and then considering dapsone or colchicine. And then for severe disease, a higher steroid dose with MMF, methotrexate, or azathioprine. So now I reviewed a handful of different types of vasculitis. I want to go over just a few mimics to keep in mind when you're thinking about vasculitis. As many of you guys know, infection can cause skin lesions that look like vasculitis, in particular infective endocarditis, and something very similar with myocardic aneurysm if they have any distal embolization. And that can be seen in the picture to the right. But there are also a few non-infectious etiologies that I want you guys to keep in mind, in particular atherosclerosis. As you know, people with high cardiovascular disease can have a lot of vessel blockage, which can kind of mimic some of the symptoms of vasculitis. Thromboembolic diseases and hypercoagulable states, both inherited as well as acquired, such as like factor V Leiden, protein S or C deficiencies, as well as acquired liver or renal disease. And then there are various medications that can cause a drug-induced ANCA vasculitis in particular, including hydralazine, PTU, and minocycline. There are various toxins that can also cause vasculitis-like picture. The middle picture on the right is an example of cocaine-induced vasculitis, and that's something that can unfortunately happen with drug use. And then lastly, I wanted to talk about exercise-induced vasculitis. So this isn't a true vasculitis, but it kind of looks like vasculitis, or it can look like that leukoplastic vasculitis that I showed initially. And that's in that final picture. It has a nickname golfer's vasculitis because it was seen frequently in people who were out playing golf all day. And more recently, actually has a nickname of Disney vasculitis because people who go to Disney theme parks and spend the whole day walking around, come back to their hotel room and they're like, what happened to my leg? So these are just things that you might want to keep in mind. And what makes the exercise-induced vasculitis different than pretty much everything else I've mentioned is that it will resolve within 3 to 5 days of onset because it's not a true vasculitis. So once you, hydrate and don't wear tight clothes and walk outside in 80, 90 degrees, things will resolve. So it's not something to be too worried about. So just to recap, I want you guys to know that many of the early symptoms of vasculitis are vague and not very specific. And so keep that in mind when thinking about people who just have generalized malaise, fatigue, maybe some sinus issues, maybe some cough, and just overall seem to not be doing well, maybe even a little low-grade fever. And even though ESR and CRP are very, very non-specific tests and can be elevated in a whole variety of conditions outside of vasculitis, anemia, malignancy, infection, it's something that we definitely want as a baseline when thinking about vasculitis as well. And so we appreciate that being checked. And then we really appreciate assistance with our primary care colleagues for managing and monitoring for our prednisone-induced side effects that we cause with our treatments, as well as helping us monitor for any relapse or regression in their disease course that requires urgent evaluation. And then as discussed on the previous slide, there are various mimics for vasculitis, and we would like those to be considered as well in terms of various infections, medications, as well as toxins that can produce these symptoms. So I have some key references, and I'd like to thank all my colleagues in the Division of Rheumatology, and I'd be happy to take any questions if you have them.